All right. Good afternoon, everyone. Today, and welcome to today's national webinar presented by Policy Research Associates, Setting the Record Straight, What AOT is and is not. I am Alon Holt, Vice President for Research and Evaluation here at Policy Research Associates, and I will be your moderator for today. Oops. In this webinar today, Dr. Richard Van Dorn from Policy Research Associates and Dr. Marvin Swartz from Duke University School of Medicine will share insights drawn from more than a decade of research on AOT, including evidence from randomized control trials, statewide evaluations, and their perspectives, and the perspectives of individuals who've experienced the AOT court process. This is the first in a three-part webinar series led by Policy Research Associates on AOT program, legislation, implementation, and evaluation. Before we start our presentation, I have some introductory items to review. To begin, we have a few disclosures. The research discussed in this presentation was supported by the National Institute of Mental Health, MacArthur Foundation Research Network on Mandated Community Treatment, the New York State Office of Mental Health, Assistant Secretary for Planning and Evaluation. And the points of view expressed are those of the presenters and do not necessarily represent the official position or policies of any of the funders of the research. For questions, if you have any questions for the presenters or regarding the technology, please type them in the Q&A pod found at the bottom of your screen. If you have updated Zoom recently, you may need to click More, the circle with three dots, to find the Q&A icon. At the conclusion of the presentation, we will address as many of your questions as time permits. We will also be recording today's webinar, and a link to view the recording on PRA's YouTube channel will be emailed to all registrants following the event. There is also live captioning for today's event. To view live captioning, click Live Transcript CC and then select Show Subtitles. You may also need to click the More icon to see that option on the Zoom toolbar. So for our agenda today, we'll get started with some opening remarks from Dr. Sarah Desmarais, President and CEO of Policy Research Associates. And immediately following Dr. Desmarais, you will hear our presentation from Dr. Richard Van Dorn and Dr. Marvin Swartz, followed by our Q&A session and closing remarks. Dr. Desmarais.
Thanks so much, Alon. I just wanted to say a few words first to welcome everyone to the webinar. We at Policy Research Associates, next slide, please, have really been focused for the last 35 plus years on helping state and local leaders solve really complex behavioral health challenges. We believe in co-designing practical and evidence-based solutions tailored to your communities. Doing this work, one thing that we believe deeply in is leading from the evidence and from practical solutions. And so today our goal is to present a very factual, unbiased representation of both what AOT is and what it isn't. With that, I will turn it over to the presenters, and I really look forward to today's discussion. Thank you.
Thanks, Sarah, and thanks to everyone joining us for the first in PRA's AOT webinar series. What I want to do in this opening section is to set the stage before Marvin walks us through the core outcome literature. Marvin and I, really tried to use this as a level-setting webinar. That is, AOT is often discussed as if it were a single intervention with a single evidence base, but that's not how it works in practice. Our goal here, is to separate three things that often get blurred together: the law on the books, the way the programs are actually implemented, and the evidence on outcomes. Then, like I said, Marvin will walk us through a brief review of the research. I like to start here because this work has always been collaborative. The evidence base we are drawing from for today's presentation, as Alon noted earlier in the funding section, has been built over decades by investigators across psychiatry, psychology, law, public policy, services research, and implementation science. For me personally, though, if you'll allow for a moment, this is also a bit of a full circle moment to be presenting again with Marvin. Marvin was my postdoctoral mentor at Duke, and a great deal of what I know about thinking carefully and critically and honestly about AOT comes from that collaboration and my work with Marvin and Jeff Swanson specifically. So it's a very cool moment for me. I think it also underscores an important point. This field has moved forward because people were attempting to answer difficult yet critical clinical and policy questions with innovative research methods, not because they were trying to defend a predetermined position. So onward then. One of the first potential misconceptions I think to address is that AOT is some common uniform thing. To my way of thinking, instead, if you've seen one AOT program, you've seen one AOT program. That may not sound very helpful, but it gets better, I think. So broadly speaking, you see at least 3 forms of AOT, or what used to be known more commonly as involuntary outpatient commitment. You see conditional release from a hospital. You see use as a least restrictive alternative to inpatient commitment. And then sometimes you'll see preventative outpatient commitment aimed at stopping deterioration before someone again meets inpatient criteria. These distinctions matter. When people say, does AOT work? They're often comparing programs that are legally and operationally quite different. And even when states authorize AOT, that does not mean that there is an active AOT program on the ground. Implementation is often uneven, largely local, and sometimes highly variable even within the same state. Generally, at a high level, there are common elements people tend to associate with AOT eligibility. And I'd like to emphasize here that I'm showing general criteria, not a universal AOT eligibility template. States phrase and apply criteria differently. Still, the core idea is that AOT is aimed at a narrow subset of adults with serious mental illness, whose treatment trajectory or treatment history suggests that without structured intervention, deterioration is likely. And finally, I want to stress here that AOT is a civil mechanism. It's not a criminal sanction, and it is intended to connect people with community-based treatment. This is where I want to shift from statute to practice. The next several slides come largely from the multi-site evaluation work that we did with colleagues across PRA, Duke, and RTI for SAMHSA's first AOT program implementation. And to me, show why understanding implementation details matter so much. The boxes, the cells don't matter so much. I want to talk generally about kind of what's happening, and we'll make the slides available so you have the specific information. There we go. So AOT statute characteristics by state. Here we're focusing mainly on 6 states that we did detailed evaluation work in. The legal structure varied a lot across study states. There's a core tenet, I think, undergirding any discussion of the use of AOT, and that is the idea that treatment can be mandated and used in a way to prevent deterioration. Beyond that, though, there's often substantial variation in dangerousness criteria, basic needs criteria, voluntariness language, and the exclusion of ineligible groups. As one example, I want to focus on Alabama real quickly, top row there. Alabama is notable because it's law-focused, at least as it was originally written, on people who already met inpatient commitment criteria. So there, AOT was structurally a step-down mechanism, more so than any of the other sites that we studied. And here's another, I think, potential broad generalization about AOT that can be misleading. Two programs may be called AOT while targeting meaningfully different populations at very different stages of the treatment process, right? Community, hospital. So all of those can be embedded in what people are calling AOT. Here across program models and target populations, I'm trying to convey that programs are not only shaped by statute, they're also shaped by local design choices. You can think of programs generally as step up, step down, or mixed, stepping up to an AOT order in the community, stepping down to an AOT order from an inpatient setting or a prison, for example, or doing both. In our 6-site work, most were mixed, but even then the target population was often narrower than the law might suggest. Oftentimes due to upstream decisions and decision makers that were attempting to balance clinical needs and available supports with public safety. So said a little bit differently, there are decisions people make about who ends up in AOT and who doesn't end up in AOT. And understanding those decisions is a very real aspect of AOT program development and implementation. And again, this matters for evaluation. If one site is functioning mainly as a hospital step down and another is functioning as a preventative community-based intervention that first emphasizes voluntary treatment engagement, I'm not sure you're going to expect identical outcomes or that the same people will be served across programs. Next, moving on, filing an affidavit, right? This is all kind of part of the process of an AOT program. So we continue to wade through various practical realities of access to AOT. On paper or statutorily, many people may be authorized to file. In practice, however, filing often falls to a much narrower set of actors: clinicians, hospital psychiatrists, or other designated mental health professionals. What also varies across AOT site is the process burden. So for example, the cost to file, the time to hearing, and procedural complexities. All of those need to be taken into account as well. So when commonalities or when communities talk about starting an AOT program, they're really talking about building a pathway and communication protocols and processes through the court, service providers, substance use and housing supports included here, and local law enforcement and emergency services providers, not just passing or having a statute in place. Continuing onto the examination and hearing, this is where due process and implementation issues around AOT can become concrete. But again, concrete in their variation across site. There's still wide variation in who can examine respondents, whether treatment plans are judicially reviewed, how counsel is provided, whether respondents' attendance can be compelled at court, and how long the initial order lasts. Again, all of these things are part and parcel of an AOT program and really important to understand. Moving on to post-initiation. So an order has been granted. Programs still operate differently. Some programs incorporate status hearings. Some require judicial review of treatment plan changes. And some use parallel guardianship type mechanisms. Renewal practices, that is extending the original AOT order, differ widely in terms of time frames. You can start out with a very short period of AOT time, and the renewal in some places can be up to a year. So again, a lot of differences. So AOT is not just an entry decision. Is your court striving to be an active court, for example? If so, what are the resource requirements, including contact hours and what can be billed and what cannot be billed? Broadly, though, issues related to ongoing supervision and service structures and the degree of court involvement after initiation vary a great deal, but are really important. Post-initiation, moving on from that, what do sites do when there's non-compliance? This is often people will talk about the teeth of AOT and whether or not they exist or not. And the short answer is surprise. Response to noncompliance vary considerably. Some programs can notify the court and potentially return the person to the hospital. Others are able to issue a pickup order for return to court, while others reported feeling like they had very little to no direct recourse and instead had to rely on or wait for clinical deterioration that was then used to justify an emergency evaluation. So I think two broad points. First, AOT programs do not uniformly use leverage or even interpret being able to use the court in instances of noncompliance in the same way. Second, I think from our work across sites, lack of a clearly formulated response to noncompliance can weaken how clinicians and courts perceive the usefulness of the order. Is as delicately as I can say that. It's important. We've talked an awful lot about the court so far, but there are treatment components. And the way I like to talk about AOT is any success, any outcomes associated with AOT aren't due entirely to a court order. Treatment matters. So across the 6 sites, AOT was tied in some way to treatment capacity, especially intensive community-based services such as ACT, although fidelity and services mix varied. Some sites essentially bundle AOT and ACT together. Others treat AOT more as a court structure layered onto existing ACT services. Here again, the distinction matters conceptually and methodologically. So when we ask whether AOT works, a better question, I think, is often under what service conditions for which populations and risk profiles, and with what degree of court monitoring does AOT work? Okay. When people talk about AOT, the first state they often think of is New York. And I think New York is worth separating because it represents a more mature and organized state level model than the more county-based examples we just walked through. New York, or what was known as Kendra's Law, had a clear administrative structure. It had designated coordinators and directors and a more formalized approach to investigating cases, preparing petitions, reviewing treatment plans, and arranging services. That level of organization, although certainly not as seamless as I am implying or making it seem here, matters because it helps explain why New York became such a central case in the AOT literature. So here then, to my way of thinking, is what mattered most in New York. Again, at least to me, there were services commitments. And before Marvin starts with the research slides, which do include some of our New York findings, I think it should be noted that I think New York's results should be considered in the context of the state's direct investment in the AOT program, in medications and discharge management, in oversight and case management slots, etc. There was money spent. So, continuing, all right, before I hand it over to Marvin, I want to acknowledge controversies exist around AOT, and I think any discussion, any honest discussion of AOT has to acknowledge the controversies. And so I just want to take a second to do this here. And this, while certainly not exhaustive, these are some of the core concerns around AOT that people have raised for years. So for example, adequate voluntary services and aggressive outreach could reduce the need for court involvement in the first place, right? Another is whether systems of care use AOT as a workaround for services failure. That is effectively blaming the service recipient for system inadequacies. To me, a fair-minded approach would seem to be neither reflexively pro nor anti-AOT. Instead, it's to ask what problem is a local jurisdiction trying to address, what alternatives are available, and what does the evidence actually say, and how can that be tailored to the jurisdiction and its local needs. So I now would like to turn to the evidence. What Marvin is about to walk through is the major US research base that has helped shape the field. The Duke work, the New York work, the broader question of when AOT appears to help. So I am going to stop talking and I am going to hand things over to my former mentor, Dr. Swartz, and Marvin, it is all yours. If you want to advance the slides, feel free, or I can.
Okay, I think I can, and thanks very much.
Thank you.
It's a pleasure to work with Richard again. Richard was really the brains behind the New York study because it was, as we get to it, you'll see there was a lot of data, a lot of complex analyses, and he was really a key person in trying to make the New York data comprehensible. I think he set up this discussion really well because I think he should have convinced you that the AOT programs vary quite a bit. And as I walk you through the evidence, I hope you'll keep that in mind because for years, one of the controversies about AOT is how you judge its effectiveness. So people and legislators always want to know, is AOT effective or is outpatient commitment effective? And I think what Richard has demonstrated is that AOT is a complex community intervention, that it varies from site to site. It varies from, it's embedded in communities that vary quite a bit. Some of the programs are statewide programs. Some are local programs. And so to apply, folks who do the work of evaluating evidence like to say that the gold standard for evaluating the effectiveness of something is the randomized trial. And I think what Richard's illustrated is that that may not be the best standard for looking at AOT because the randomized trial fits best when you're talking about a drug trial. So if you're asking the question, does aspirin help prevent heart attacks? Well, there's not a lot of complex community intervention involved with that. Someone takes the aspirin or they don't. Whereas in AOT, it really depends on its implementation. So rather than asking, is it effective? We like to say, can it be effective and under what conditions? And I know that makes it a more complex question, but it's a more honest way to think about it. And saying that if you don't have a RCT that demonstrates the effectiveness of an intervention, there's not adequate evidence. And if you look through the critiques of the literature of evidence, you'll see that that issue keeps coming up, that there are people who will only privilege the RCT and say if the effectiveness isn't demonstrated by an RCT, there's no demonstrated effectiveness. And you see that in Cochrane reviews, you'll see that all over the place, where people think that's the sole standard. And I want you to sort of suspend disbelief about that and look at the evidence, the selective evidence that I'll talk about today. Now, way back when I was a young pup and I was working at Duke, I worked in inpatient unit, I worked in the emergency room, and I worked in the prisons in North Carolina, in various prisons. And one of the things that struck me in those settings was two things. One is those populations looked very similar, that there were folks with, at least the folks that I was taking care of, had very similar characteristics and mental illnesses, one. And two, not only did they have similar characteristics, but the thing that really connected them was that while they were under supervision, while they were in inpatient, for example, they had sort of uniform delivery of their treatment, including their medication. And then when they left, due to a host of factors, they tended to be non-adherent and they tended to relapse. And so we started with colleagues to say, well, North Carolina, where I live, has this law in the book called outpatient commitment. Would that law, if you designed a study of it, prove to be effective? And there were plenty of people in North Carolina said, no way, it won't work. It's a dumb law, it doesn't work. And so we designed a study in these counties, which is the north central region of North Carolina, which feeds into essentially one state hospital, but we actually work with the hospitals throughout the region. And we got each of the then area programs to suspend disbelief about outpatient commitment, whether it would work, to enter a study in which people coming out of an inpatient hospitalization, so coming out of involuntary inpatient hospitalization, they were returning to the community on outpatient commitment. So that's what Richard is referring to as a step down. Now, there's a big difference between a step down and a step up in that in a step down, the person is leaving a more supervised environment, a more, quote, coercive environment, and is entering a form of community supervision. The difference between that and step up is in a step up, the person is sort of de novo coming into supervision. So we designed this study of step down, and we said to each of these entities, the Durham Mental Health Center, Orange Person Chatham, Vance Granville, Franklin Warren, and actually later Guilford County. And we said, suspend disbelief or whatever belief you have about outpatient commitment and enter in this study with us where we're going to randomize people coming out of the state, coming out of involuntary inpatient commitment to outpatient commitment. And half of those people we're going to relieve of the court order. We're going to go to court and file papers to release you from outpatient commitment. And everyone in the study, whether they're in the outpatient commitment group or not, will get consistent, relatively intensive case management. So it was then a study of whether AOT or outpatient commitment exerted any benefit over and above the effect of consistent case management. So that's the basic setup of the study. And anyone who entered the study was in the study, unless they, withdrew consent, they were in the study for a year. Now, it didn't mean that their dose of outpatient commitment lasted a year because you had to go back to court and show that the person still met criteria. And so people, unfortunately, for the design of the study, had variable doses of outpatient commitment. And that was sort of baked into the law that we couldn't guarantee that someone was purely going to get no outpatient commitment or a year of outpatient commitment. However, anyone who was in the arm of the study that got no outpatient commitment were immunized against it for a year. So if someone inadvertently put them under an outpatient commitment order, we had the privilege of going back to court and releasing them. So you have two groups here. One group that's under outpatient commitment or AOT with case management, and one group with case management alone. So we followed them all for a year, and these are some of the results. We have a lot of results, but the first result is that the group that was under outpatient commitment, they were in that arm of the study, were a third less likely to be readmitted during that year. Now, that finding is significant if you look month to month. And one of the controversies about this trial is how it was reported. But the straight up story is that if you look month to month throughout the year, you're a third less likely to be readmitted during that year. We also found, and this is what sort of confused the reporting of it, that finding was most largely resided among people who ended up getting longer doses of outpatient commitment. So the initial dose could only be up to 90 days just by law. But the people who essentially got renewed and got 180 days or more of outpatient commitment were far less likely to be admitted to the hospital again in that year. We also found that they had much shorter hospitalizations. Now, this is a study that was in 1999, or we reported in 1999, when lengths of stay were much longer. And we found that roughly the average length of stay of people in the control group or people with short doses of outpatient commitment had about a month of hospitalization, but those under outpatient commitment got about 7 to 8 days of hospitalization, so remarkably shorter periods of hospitalization. We also found that those who had these longer periods of outpatient commitment were far less likely to be violent. Now, let me clarify this because this has been distorted quite a bit. It's not extreme acts of violence. It's not gun violence. It's a sort of violence that happens in the daily lives of people with severe mental illness, of pushing, shoving, fist fights, but not extreme acts of violence. Those were very rare. And we can't report on that. But you see here in this final row that if you got longer periods of outpatient commitment, you were less likely to be violent. Right there. And you see that here, that if you had extended outpatient commitment, your likelihood of violence was 24%, and everyone else, their likelihood of violence was 42%. So it remarkably lowered the probability of any violence. But again, the caveat is we're not talking about severe violence. We're talking about sort of everyday violence that happens in people's lives. The other finding that was very remarkable was that people who were under any length of outpatient commitment were far less likely to be victimized. They were far less likely to be a victim of a crime or an assault. So you see in that group, any outpatient commitment reduced their risk of being victimized to 23% compared to about 42% for the rest of the sample. So because outpatient commitment was so controversial and there were so many critiques of the practice, we were interested in going beyond just the hospitalization as an outcome, because it is only one outcome. And we wanted to ask a series of other questions. What do people under outpatient commitment have a better quality of life? Do they think they were benefited from outpatient commitment? And if you look at people's preferences and what they would prefer in terms of being under outpatient commitment, we want to understand that too. And so these are 3 different studies that we conducted. The first was the subjective, what they reported as their subjective quality of life. And you see here that those who had renewed or extended outpatient commitment reported subjectively that their quality of life was much better compared to those who had a short period of outpatient commitment or had no outpatient commitment. When you look at whether they thought they benefited, there was this theory that was promulgated by a famous forensic psychiatrist, Alan Stone, excuse me, who said one way you can evaluate a practice like involuntary commitment is to go back to the people who were subjected to them and ask them if they thought they were better off because of what had happened to them. So that was called thank you theory. Did people under outpatient commitment at the end of the day say, thank you, I needed that? And what we found is they did not. And if you look here, what you find is of in the total group of people under outpatient commitment, 27% said yes, they needed it and it was good for them. It was something that they benefited from. If they had a bad outcome, so if they really didn't do well under outpatient commitment, only 20% endorsed the benefit. But if you took people who had a good outcome, they endorsed a personal benefit at 45%, but it's still a minority of people. So you can't really evaluate outpatient commitment by asking people, were you better off or do you want to thank us for doing it? It just is not a reality, at least in this study. And then the final study we did was we asked 4 stakeholder groups. One were people caring for folks with schizophrenia. The second was a group of people with schizophrenia, a group of family members, a member of the general public. And we gave them vignettes in which they were really evaluating the trade-off between being under outpatient commitment or benefiting in some way from outpatient commitment. And what you see here is when you look across the 4 stakeholder groups, so there was fair unanimity about this. In fact, the direction was consistent. A small amount of importance was attributed to avoiding AOT. So people did not, by and large, say, the most important thing to me is avoiding being under outpatient commitment. But a large proportion endorsed the idea that they wanted to avoid rehospitalization, that it was very important to them to stay out of the hospital. And in effect, what this is arguing is that actually the way people evaluate things like this is that they see it as a trade-off. It's not that people are walking around, at least in my view, saying, I don't want to be coerced or I'm not going to ever accept coercion. That when you ask them the question, they're saying relative to what? And so if you ask a person with schizophrenia, how important is it to avoid outpatient commitment? I think the way they think about it, and all other groups think, well, relative to what? If being under outpatient commitment keeps me out of the hospital, if it keeps me from being victimized, if it helps me get along better with my family and friends, then that's a fair trade-off to get those benefits. So if you accept the evidence that these are the things that outpatient commitment benefited from our study, you would say that stakeholders in evaluating the importance of these outcomes would say, avoiding outpatient commitment isn't as important as having to be hospitalized again, likely against one's will. So those were some of the things we had evaluated in the North Carolina study. And now we'll move on to the New York study. And this was a study that was a contract from the New York Office of Mental Health, which was mandated by the legislature to evaluate Kendra's Law, or the AOT program in New York. The New York program was very controversial, and it was written in such a way that it had to be renewed every 5 years. In the first year of the AOT program, and you saw the finances of it from Richard earlier, which is, I think, very important, that there were real carrots to a program that people regarded as having a lot of sticks. That a lot of people said, whoa, if I can get 125 million additional dollars for services in New York, I might be willing to accept this program. At any rate, in the second 5 years of the AOT program, they bid out to researchers this idea of evaluating the AOT program. And we were fortunate working with the MacArthur Foundation, as Richard referred to at the beginning, and PRA. And Richard at the time was with us at Duke um, to get the contract to evaluate it. Now, when we looked at the options in terms of doing the evaluation, we decided that a randomized trial was not the best way to get at this, that we thought a more naturalistic study that took as many people as possible who were experiencing AOT under our research program was the most naturalistic and most effective way to evaluate how good the program was, how effective it was. So, as we said, it was legislatively mandated, a study of Kendra's law from 1999 to 2007. And the design was an observational study with multivariable analyses of time series data. Now, that's a big mouthful, but what it says is it's a study of everyone we could study who were in AOT. So that's, look at the sample size. We had 3,500 people that we could study. Whereas in our RCT, I didn't show this in North Carolina, but that was 250 people. So there's just a huge order of magnitude bigger in having this study, even though it's a pre-post observational study using statistical controls. So we acknowledge it's not an RCT. It's not the gold standard for some people who think about evidence, but we think it was the most cost-effective and reasonable way to look at it. And the outcomes we looked at were hospital use medications, receipt of ACT and intensive case management, and other forms of case management. Now, look at this column here, because I think it's a big take-home message for people who try to understand the literature. And I think it's typical. It holds up in North Carolina too. And this is, where did the AOT order in New York originate? These are the different regions of New York. And you see most of the cases are coming from New York City. It's mainly a phenomenon of the area around New York City. Many fewer cases upstate and elsewhere. But look at where the cases are originating. More than 80% are starting out in the hospital, so they're mostly step downs. There is a smidge, and an important smidge, of people who are stepping down from jail or prison. And this is the smidge less than 20%, probably about 18% or 17% of people who are getting step-ups from the community. And some of them were probably not step-ups. Some of them were renewed orders. So it's very important to realize that the overwhelming number of people that are in the AOT program in New York and at the time in North Carolina were people who are stepping down and for whom this was a less restrictive alternative, which is an important part of the argument about AOT. These are some of the outcomes. We have a ton of outcomes, and I recommend to you reading the full report that's online at OMH. Or we had a series of reports in psych services that detail this. But you see, for people under AOT, they were much more likely to receive ACT or ICM. It was almost 2.5 times higher if they got some form of intensive case management. They were far more likely to get and consistently have appropriate medication for their condition. So we looked at their pharmacy records, and in order to be positive on this, 80% of the time you had to have a full supply of an appropriate medication on your record, so in a Medicaid claim. So you see the receipt of medication appropriate to one's condition went way up, as did reduction in hospitalization, as did days hospitalized. And this is a finding that I think is very important and unfortunately is not as well known. Many people will say, well, and Richard presented this as one of the critiques of AOT, and they say, well, if people got the Cadillac of services, they wouldn't need AOT. So if they got ACT or if they got intensive case management, then you wouldn't need AOT. You wouldn't have any benefit of AOT. And in this analysis, what we saw is that those people who got AOT over and above getting a assertive case management or ICM, intensive case management, did do better. That AOT did exert an additional beneficial effect, and it reduced hospitalizations considerably for those participants who received AOT plus intensive services compared to intensive services alone. Now, one caveat about this is observational. It's not an RCT design, but I think it's powerful evidence that AOT is doing something over and above ACT or ICM. It's not telling you what it's doing, and it could be doing a bunch of things that we can't account for, but something's going on here in adding the court interaction over and above case management. We also saw that people who were under AOT were less likely to get arrested this is a little complicated, so I won't dig into it other than to tell you, compared to baseline, before they got AOT, they were less likely to be arrested. So let me just summarize this part of the study. And what we said is we found that AOT did improve a range of important outcomes for recipients, and that the increased services available under AOT clearly improve recipient outcomes, but that the court order and its monitoring do appear to offer additional benefits in improving outcomes, and that the AOT order in and of itself exerts a critical effect on service providers as well. And our theory of action of AOT is that and we studied this in North Carolina, is that the effect of AOT was to alert service providers that they needed to follow these people more closely. It sent a message to the patient that people were concerned about them and they wanted them to be as compliant as possible. And it also alerted the families or the significant others that this person was under court order, and people had to work together to try to improve treatment adherence. So we don't think it's a single theory of action. It's not just the court order. It's a synergistic action between the court order and the effect on the service providers, the effect on the patient, and the effect of the families and significant others. So we also looked after this study. We had concluded the piece that was funded by OMH and the MacArthur Foundation. We then wanted to do a cost study, although it wasn't part of the original study. And this was the part I think that tortured Richard the most, because it was a very complicated piece of analysis. But what you're looking here is costs, overall costs for different buckets of people's care in before AOT. The first column is before AOT, and then during AOT, and then the first year of AOT, and then the second year. So you see that the cost of AOT legal services and program administration, there was no cost before AOT, and then it averages out in the 5,000 and goes down a little bit. And then you see hospitalization not funded by Medicaid is about 50,000 a year pre-AOT, and then drops down to about 11 to 13,000. You see the same for Medicaid hospitalizations. And then you see an uptick in outpatient services, which you would expect, mental health services, and then in medical services, and criminal justice services is relatively flat. So you see that the cost, there is a compensatory increase The trade-off is that you have to spend more money for the services because people are going to get more services. But the big savings are in the hospitalization buckets. So let me just go back there for a second and for you to think about this for a minute. So when you say, well, does AOT save money? The net over all these different buckets is a considerable savings. So the total cost of the program in these different buckets reduces the total cost by about 50%. So considerable cost savings. However, it's not always in the same bucket. You know, like this bucket, the Medicaid bucket, is savings to the Medicaid program. And that's, since it's a federal state program, about, you know, maybe a third of the savings are received by the state in their contribution to Medicaid. But in this bucket, the entire savings are to the state because these are services that are directly subsidized by the state. So while it's not all in the same buckets, these are maybe different budgets, the net cost savings are about half and considerable. So let me stop there, and I guess we're open for questions.
Thank you, Marvin. That was amazing. We have one quick question while we're still kind of in the mind of thinking about North Carolina. There was a question, how did the state, North Carolina, ensure that the outpatient commitment law was getting interpreted in the same way within each county in North Carolina? The questioner says that seems to be a challenge we have related to similar laws in our state. I'll let you address that one.
Yeah, that's a great question. And for the study, all those counties in the study agreed to a study protocol. And we had materials in which they were given direction about how to interpret the law, who was eligible, protocols. And so we had uniformity within the study sites. I don't know that came up that much in other counties. And part of the answer would be that many counties weren't using it that much. There's huge variability in who was using it. So it was an issue that came up.
We have a couple of more minutes, and the reminder from Alon, use the Q&A feature to post any questions that you have. I want to move real quickly while some of those may be coming in to the closing remarks. And I will go back, sorry. Why did that jump so quickly? There we go. I think Marvin talked about, and I really limited what Marvin, the time that Marvin had, which meant that Marvin and I had to cut a lot from his normal slide deck. There is a lot more evidence that is relevant and interesting. There is also other evidence beyond, certainly research that Marvin has led and been involved in. Marvin mentioned a couple of the leading evidence reviews, a RAND study. We mentioned the Cochrane collaboratives and their impact and use of RCTs and AOT. There are also U.S. studies. We mentioned the Duke Mental Health Study, the New York Bellevue Study. Former president of PRA, Hank Stedman, led that. And then there's the MacArthur Research Network. There's our New York study. And then there's the multi-site AOT evaluation that we worked on with, like I said, colleagues across Duke, PRA, and RTI. But I think the fairest reading of the evidence, and as Marvin has said, when considering can AOT be effective and for whom, it's an outpatient commitment, or AOT, is a complex community intervention. As Marvin mentioned, it's not easily evaluated in an RCT, drug A versus drug B. I think the fair-minded reading of the literature on outpatient commitments effectiveness would be that it can be effective, assuming tailored program implementation, targeted and appropriate program entry, provision of intensive community-based services. Again, I will repeat, substance use services and housing supports are included here. Also, an adequate duration of the court order. I think, oh, sorry, I blew right past a slide. Contact information for Marvin and I. A question just came in. Marvin, in the absence of adequate services, AOT may be a false promise. Is there any comparison of an adequately funded voluntary outpatient program and an adequately funded AOT program?
Well, we have one thing we showed in the North Carolina study was that, and I'm sorry I don't have this slide, but among people who got a ton of services, if you didn't have intensive services, AOT didn't work. So it's an indirect answer to that question. That for people who didn't get an adequate dose of, you have to have an adequate dose of AOT and you have to have intensive services. And for people who we had a comparison of people who didn't get intensive services and got AOT, and those people did poorly. So it was the synergism between service intensity and the dose of AOT that worked. And that's my best answer to that question, is that, and also local conditions matter too. In a place in which you have a tougher slog to provide services, like, if you have, like a good example is in North Carolina, when we were doing this study, our rate of homelessness among the people we were working with was about, I think, 10%. And in the New York study is closer to 50%. So that matters too. It's a whole range of services. But it's a great question. I wish I had a better answer.
Yeah. Marvin, another question came in. What is the definition of adequate dose for AOT? 180 days at least?
Yeah.
Yeah, I mean, that's kind of where you've always cut it, is 180 or more, right?
Correct.
Yeah.
Correct.
Okay. We're running low on time, short on time, and I want to take a minute before we wrap. Thank you again, Marvin. I want to take just a second to talk about the next webinar in AOT, in PRA's AOT webinar series. So specifically on Thursday, May 7th, Dr. Cindy Gibson and I will be presenting results from her Mobile County, Alabama AOT program. Cindy is Director of Crisis and Justice Involved Services at Alta Point Health, in addition to being an assistant professor in the Department of Psychiatry at the University of South Alabama. Much like with Marvin, I've had the great fortune of working with Cindy, gosh, for over a decade now, collaborating on the development and evaluation of her Baldwin County AOT program first, many other projects, and then now for the second webinar on the development of and evaluation of her Mobile County AOT program. I think what makes this next webinar so great is the depth and specificity of the data that Cindy and her team have collected. So not only will we be presenting brand new results from pre, during, and post AOT periods from over 500 AOT orders, outpatient services, inpatient encounters, arrests, the things that Marvin just talked about, and so much more. But the evaluation is based on multi-year follow-up data. So what happened after the AOT order ended, we didn't talk about that much today. We have sometimes, in some instances, up to 5 years post-AOT data, which is pretty amazing. And then the data collection protocol that Cindy and I developed and her team implemented. We have detailed law enforcement data, so not just arrests for new crimes or revocations, but police contacts that didn't result in an arrest, for example, and also data on officer use of force during an interaction. So this level of detail is And with me being a good scientist and mentored by Marvin, I'll caveat the next statement with, at least to my knowledge, this level of detail is very, very rare. It's unheard of in this field. And we're excited to share results that we think are some of the most AOT policy and practice relevant to come around in a while. If you're thinking about AOT, whether from a policy, clinical, or an implementation standpoint, I think that the next webinar will be valuable. And it's where we try to move the conversation from what does the research say to what does it look like in practice and what can we learn from it. So look forward to seeing everyone again May 7th. I think thank you and have a great rest of your day. Alon, do you have anything to close with?
Yes, just thank you all for participating in today's webinar. PRA helps communities answer the right questions before establishing or expanding AOT programs. We co-design implementation and evaluation strategies grounded in the evidence, existing capacity, and local priorities to address your community's needs. If your community is considering starting or expanding an AOT program, we can support the design, the planning and evaluation, ensuring that you answer and ask the right questions. So please feel free to join our listserv, visit our website, and we hope to see you at our next webinar in this series. And thank you, Dr. Van Dorn. Thank you, Dr. Swartz, for a wonderful presentation of the AOT research. And thank you, everyone.
Thanks, everyone.
Thank you.
Thank you. Bye-bye.